Good morning, everybody. Welcome to the South West London ICB board in public. My name's Mike Bell and I'm the chair of the ICB. Really warm welcome. The meeting was originally due to take place in Kingston, but because of the announcement by the BMA about overlapping strike action between junior doctors and consultants, it was decided the meeting would take place virtually. That allows our chief executives and other NHS staff to stay closely in touch with things on the ground. We do apologise for any inconvenience this has caused, but I'm sure that you understand in the circumstances, this is a wise thing to do. This is a reminder that this is a meeting held in public. It's not a public meeting. There are opportunities for questions at the end, although as this is a virtual meeting, they will have needed to be submitted in advance, and we do have questions at the end. It's being broadcast online and recording will be uploaded to the ICB website after the meeting. A version of British Sign Language will also be produced to ensure accessibility. We have received some apologies for this meeting, so if I could go across to Ben. Ben.
Thanks, Mike. So we've got apologies from Dame Callie Palmer, Mercy Jo Singham, Martin Spencer and Mike Jackson, and James, I think you have to leave part way through as well.
Thank you. We've had no further apologies for the meeting, and I confirm that the meeting is quorate. So we'll move on to declaration of interest. A register of declared interests included in the pack of papers. Can I just confirm with board members that there are no additional interests which need to be declared or any which need to be highlighted due to items on the agenda today? Can't see any hands going up, so if we could just note the register of interests. We'll move on to the minutes and the actions arising from the ICB meeting held on the 19th of July. Can I ask colleagues to indicate if they are unhappy with the minutes? Again, I can't see any hands going up, so I'll assume that we can accept those minutes and we'll duly note them. Moving on to the action log, there are 4 open actions which are not due until completion later in the year. There is 1 action in relation to Health Watch. Could I just check, is there an update in relation to Health Watch?
Yes, we're on the verge of publishing a report on children's mental health. Unfortunately, it wasn't published before this meeting, but we're anticipating it'll be done in the coming weeks.
Lisa, thank you very, very much, and do make sure that our communications team are kept in the loop on that, and we'll make sure that we give it the appropriate publicity. It's an important piece of work. I know there's a huge amount of public interest in children and young people's mental health, so we know it's going to be an important report. If we could move on to decisions made in other meetings, and particularly the Part 2 meeting, which was held on the 19th of July. And can I pass across to Sarah?
Yes, thank you very much, Chair. So we did agree that there was 1 action. There is around an existing urgent care contract in Croydon, and we agreed that when that contract lapses, the Croydon Health Services acute and community contract would default. It would default to them for that urgent care provision. So that is, and they're the existing providers. So that was the agreement of the board.
Great, thank you very, very much, Sarah. We'll move on to my report, which is included in the pack. I wanted to just highlight a couple of areas which I think it's worth highlighting. First of all, to highlight Asian Heritage Month, which ran from the middle of July to the middle of August. Really, really important event, and we know that we have substantial South Asian communities across South West London. So it was really good to see a series of events celebrating that. The report, the chair's report, highlights a number of awards that South West London has secured, and I think that demonstrates the level of both the level of innovation, but also the level of quality that we have in Southwest London. So congratulations to all of those teams who are represented in the various awards that are listed. I'm also really wanted to really highlight the virtual awards programme. I think it's one of the areas that we can be rightly proud of in Southwest London. It's very much the future of one of the key features of healthcare that's going to ensure that we have sustainable services. We know that it has significant advantages for patients in terms of the speed of recovery, and it's also really, really important in terms of the levels of efficiency that we can drive into the system. We are leading in that area, and I'm really pleased that we're now sharing our knowledge more widely with our other colleagues. The final thing I wanted to draw to your attention is that we have our annual general meeting, and that will take place between 2 and 4 next Monday, 25th of September. It's going to take place in Wimbledon at the Everyday Church Auditorium. Everybody is welcome to attend. And I think we've got a really nice event planned. It will be a double AGM with the end of the CCG and the start of the ICB, the first 9 months of the ICB. But we'll be showcasing some of the programs that we funded under our innovation fund, and we'll be having members of those teams and the public presenting at that event, which I think will be a really exciting event. So I do hope you can join me at that event. Moving on to our core issue for discussion today, and we have a couple of those. The first one, and as the weather begins to change, James, Jonathan rather, feels appropriate to move into the space of talking about our winter planning, which I think started probably in about April this year. But over to you for the highlights from the report, Jonathan.
Thank you very much, Mike. Thanks for the introduction. And I just wanted to start by, as you've said, acknowledging the immense amounts of work that's taken place, really actually since the turn of the year. We started talking about this winter plan as people were stepping down, I think, from last winter's experience. So do want to start by acknowledging the huge amount of work that's gone into place across the system to develop this plan, and actually the huge amount of effort that's going to take place over the coming 6 months to implement it and make sure that we deliver the right care to patients over this period. The paper does obviously seek to provide some assurance to members of the Integrated Care Board about our urgent emergency care plans for this winter. But in addition, there was three questions I thought might be helpful to raise at the beginning, and I'll come back to them at the end if I might, Mike, just to see once people had a bit of time to reflect on them. So the first is, having had an opportunity to review the paper and to listen to what I'm going to talk through, have we put the right critical actions in place? That's a really important question that I think we need to ask ourselves. As you said, Mike, as the weather begins to change, we probably have a few weeks more before the full impact of winter is felt, though of course the pressures are already very acute in the system. But my second question would be, is there anything more that we can practically do to support the system over the next month or two as we step up our preparations? And the third question would be, how as a leadership community are we going to work with our teams through this difficult period? And it will undoubtedly be a difficult period, and we represent the leadership community of South West London, so I think an important question for us to ask ourselves. It's really easy actually to focus on all the challenges and pressures around urgent emergency care, and to be fair, I will over the course of this conversation. But I did want to start by noting there are some elements of change and progress that we've seen over the last year. So, for example, if we take August of this year, so last month, and look back against August of last year, you'll see that we've reduced our 60-minute ambulance handover delays for patients in the back of an ambulance outside of hospital by 78%. That's a really significant achievement for those with undifferentiated need who need access to care. You can also see a critical measure of mortality and morbidity, 12-hour emergency department waits. They're down 7% year on year. And you can also see our 4-hour wait performance has improved slightly year on year. Now, none of those measures are where any of us would want them to be for our system, and I fully acknowledge that, but I think it's important to start by saying there are elements where we have made progress over the last 12 months, and you can see that, and there are elements of evidence of stability in our system as we move into planning for this winter. So the journey to develop this plan really started in January when the national priorities were set for the year ahead. And actually those 5 national priorities seem quite sensible to me. So just to highlight people and remind people of what they were. So it's about more urgent and emergency care capacity, so more general and acute hospital beds, which we will have in place in this system. It's this year. It's about workforce size and capacity. It was about discharge processes, an area of never-ending and ongoing focus where we need to continue to think about what we can do both in hospitals and out of hospitals. It was about expanding care outside hospital. So to your point earlier, Mike, about virtual wards, that's a very key example of expanding care outside the hospital setting, but also the work we're doing on things like urgent community response and enhanced care in care homes and our ongoing programs of work there. And finally, you can have all the amazing services in the world, but if you can't access them, that's not what we need for patients of South West London. So thinking about how we improve access through primary care, through 111, etc. So those are the 5 drivers that were set nationally for how we thought about our plans as we developed them. So then moving forward into the spring, into March, April plans at a time. So we started to develop the plans locally, as I've already alluded to. We've tried to be clear about the money as early as possible in the year. So the decisions were made on some of the financial commitments, both around the winter funding for the NHS and the Adult Social Care Discharge Fund, working together with local authorities. They were made early in the spring and early summer. So we've continued to ensure that people have an opportunity to appoint substantively to roles which they might not have had done in the past in order to get the right services in place for this winter. So we're hoping that early notification, early planning puts us in good stead for the period ahead. The paper does note some significant constraints. Some are more or less within our control. COVID and flu presentations. We see some of the trends from Australia at the moment. So we need to be mindful we're not fully aware of what those will bring to us over the coming winter. The ongoing period of industrial action and the workforce gaps that presents significant risk to us through this period, and also the challenging financial context we're working in is another area that we need to acknowledge. Yet even in that context, we have set as a group of senior leaders an ambition to achieve 80% 4-hour access this winter, and improve category 2 performance. If we do that, that would potentially access additional capital into South West London for next financial year. But it's really a call to arms to our system to try and do all we can to give timely access to care and services over this winter. So if I now move on to talk about a few of the slides that have people who hopefully had an opportunity to look at and review. So if I start with the slide, I think it's 25 in the deck, but just to flag it to people, hopefully people have it in front of them. And I just wanted to draw people's attention to that infographic and some of the trends that we're seeing in urgent emergency care this winter. So, as I said, we will have 100 or so more beds in the system for midwinter than we do at this point in time. We'll have significantly more virtual wards in place this winter than we've had previously, and we'll also see some further step up in our urgent community response. But it's also true to say attendances at our urgent emergency care departments, though it may not feel like this, they are down year on year. Yet, even within that context, discharge and flow remains really difficult, and we're not really seeing the improvement in those measures that we would want to see year on year as a system. But that slide gives some sort of overview in numbers about where we are and what some of the challenges are that we face. Slides 29 through 31 in the deck set out some of the further national ambitions that we've been asked to consider. They include 10 high impact areas of intervention, and slide 31 sets out for the 4 local systems, for our 4 A&E delivery boards, what people have chosen as the priorities to focus on within that for this year. And then moving on then from the national piece and the national context, the national priorities, the main part of the document is very much about our local response and our local priorities, and it walks through 14 areas covering the full array of our urgent emergency care pathway and what we need to do over this winter. And of course, given time, I won't go through each slide in detail, but I did sort of want to at least mention one thing from each slide, if I may, Mike, just to draw people's attention to some of the key themes. So if I work my way through them, so starting with ambulance handover, I've already said that we've made some progress on the longest delays of ambulances arriving at hospitals, and there's been some really good work between the London Ambulance Service and all our trusts around improving flow at the front door, the halos as they're called, the liaison officer roles between the trusts and ambulances are embedded and are working well in our system. And we're also piloting at St George's and then planning to roll out more widely, more timely handover of patients who've waited 45 minutes or more to arrive in the department. Hopefully that's a reducing number of patients given the inroads we've made into really long ambulance handovers over the last year. So some real progress there. On the next slide talks about same-day emergency care, or SDEC, as we call it in the system. We're the only part of London to have SDEC in place 12 hours a day, 7 days a week at all our sites, which is a really strong model. And the slide talks in some more detail about some other areas, for example, the trusted assessor work that we've been doing at Croydon. But it's also true to say that SDEC capacity has often or occasionally ended up in a bedded state through some of the challenges that we've got at this point in time. And we, I think, all recognise that in order to ensure the best flows for patients and timely avoidance of admission, we need that capacity to remain free and to flow effectively, and that's one of the areas and priorities for the Urgent and Emergency Care Board that Matthew and I co-chair at the moment. The third area we chose to draw particular attention was the work on frailty services. Of course, this is hugely ongoing a piece of work around expanding our services, so ensuring they're available 7 days a week and are working effectively, expanding the proactive element of those services. And as we've already talked about earlier, some great work that we've been doing really for the last decade now on enhanced care in care homes to ratchet up the support that we provide to care homes to avoid people going into hospital when they absolutely don't need to. So that's a real key priority. The next area 4, is about flow through the whole pathway. So that's both in the hospital setting and what we're doing there to try and improve through things like transfer of care hubs, that patients leave hospital in a timely way, in a joined up way with local authorities, and also in our intermediate and community services and how we step capacity up in those settings too. The 5th area talks about virtual wards, as you say, an area we should rightly be proud of. We continue to step up the number of beds to 425 is the plan for this winter. Having said that, our utilisation is still not where we would want it to be, and it's part of the intensive work we're doing around cultures and understanding across secondary and primary care to try and make the most of that new service and that new capacity we're building for the future. Well worth going to see it, as I have done in action. That helps to garner some enthusiasm, I think. So the 6th area is urgent community response. We're actually recognised both regionally and nationally, as the slide notes, for doing some really good work in the space with really timely 2-hour urgent care response across community arms and community providers. And I think there may be some further opportunity to go further and faster with what we're doing around urgent community response to build on the good work there. Primary care is the largest single part of the urgent care pathway in terms of the volume of patients that go through it. So reflecting on some of the learning from the sort of Strep A issues that we had last year, thinking about what is the right respiratory and access, extended and additional access capacity that's available through this winter period. And the slide sets out some thoughts about that around primary care, but not just general practice, but also things like pharmacists and the support they can provide through this period. The next section covers 111. The key aspect there is trying to make sure we have the right workforce in place this winter to deliver what we need to, and also to implement this autumn the mental health Press 2 function for 111, giving more timely access to mental health patients. Which then leads on to the slide 9, which talks about acute respiratory infection hubs. We've been thinking with our 4 local A&E delivery boards, what's the right answers around acute respiratory infection hubs, and we're reflecting on some of the learning from some of the peaks in demand that happened last winter, and putting additional sessions and time in as appropriate to support any spike when we need to, and trying to be fleet of foot and adaptable to put the right thing in place at the right point in time. COVID and flu vaccines started this week, didn't it? There's a sense, I think, that at least among some elements of the population, people are a bit jaded about getting access to the COVID and flu jabs. We need to do everything we possibly can for those cohorts who are eligible to ensure access. And against one of my earlier questions, that would be one of the things we can do over the next 4 weeks, try and max out what we do around COVID and flu vaccination for vulnerable patients, but also for our staff. The mental health challenges set out on slide 11 and the ongoing pressures that we're seeing there. We are doing some work across the system to think site by site what more we could do to manage those emergency pressures between the hospital and mental health colleagues, as well as thinking about the Press 2 for Mental Health Service and some of the changes the police are bringing forth this winter. So there are plans there, and there is investment in our winter plans into mental health too, as there is into a whole range of other areas, as people can see from the end of the slide deck, as well as trust. So, for example, homelessness gets a specific area of focus and attention. Slide 12 talks about the System Coordination Centre, building on the good work that was done through the pandemic to establish this, moving more towards real-time understanding of what's going on in the system, so we can protect the system from unnecessary returns and unnecessary escalation requests, which I know is hugely time-consuming for people. And then section 13, almost there, folks. Section 13 is about sufficient workforce, having the right workforce, what we can do to flex shift patterns, support people through this really difficult periods of industrial action, provide support and mutual aid between providers. And then there is a section, sort of section 14, on the comms and engagement element. So how we support behavioural change, how we work with the voluntary and community sector, also to use often relatively small sums of money to do the right thing, so that we can ensure patients have timely access to services and understand what's available to them. And we've done I know also through the Adult Social Care Discharge Fund, there's been a great deal of work done with the VCSE sector on things like handyman type services, sitting services for people who are leaving hospital and feel that they need some additional support, even though that they might not have a medical need at that point of time. So there's a whole raft of thoughts and suggestions around there. I think it's worth noting that this plan has been well received by a number of local stakeholders, but also informally by NHS England. I've had feedback from them. And it's also worth noting that urgent emergency care systems are rated into one of 3 tiers, and we are the lowest tier, tier 3, so the tier of least concern nationally. Despite all of that, I wanted to return to the earlier theme of how absolutely challenging and tough this winter is going to be. And the system is going to creak at times and be really challenged. And we need to think how we can provide the support to colleagues to help manage that as best as we possibly can, which really returns me back to my core 3 questions, as well as seeking confidence from the board that they're assured about the proposals that we've put forward. Just to remind colleagues again of those 3 areas and that I would personally value people's reflections on. So have we got the right critical priorities and areas focused on? Is there anything more that we can do over the next month or so to shore up these plans to deliver even more effectively for patients? And how, as a leadership community, are we going to support each other and support our teams through what will undoubtedly be another really challenging winter for the NHS? So I wanted to say thanks very much for listening. It's not always that easy to listen in a virtual environment for somebody talking for 20 odd minutes, but thank you very much for listening. I wanted to, if it's okay, Mike, hand to Matthew as the joint SRO for any reflections Matthew has, any additions he wants to make to what I've been talking about over the last period of time, and then obviously very happy to take any questions. So is it okay, Mike, if I ask Matthew to add any supplementary comment?
It would be really good, but just so that people have a little bit of advance warning on what I'll be doing after Matthew's said his piece, I want to get a little bit of a flavour from colleagues about some specific areas. So I will go to John first as our CMO to give us a bit of an update on the latest epidemiological planning around COVID and flu for winter. Assuming that he's had that briefing from our London Director of Public Health. I'd then like to go to Annette and Nicola to say a little bit about the primary care approach. I'd then, bearing in mind the priority areas for each of the places, would like to go to Jacqueline to say a little bit about SDEC. I'd like to go to James to say a little bit about the urgent community response piece. To Joe to say something about the inpatient flow, and back to Croydon to say something about frailty. That gives you the opportunity to think of something quite concise, which will provide a bit of assurance to the board in those areas, but a bit of a flavour of the work that will be happening on the ground. But very happy to hand across to Matthew, first of all, as the SRO in this area, to give us his reflections. I know it's been a huge amount of work over many, many months, and I think you've captured all of that work really well, Jonathan, in your presentation. Matthew.
Thank you, Mike, and thank you, Jonathan. I mean, I won't extend too much. I mean, my overall reflection is, we started earlier. It's more comprehensive than in previous years, and I think it's a strong plan, and I would definitely commend it to the board. But I would say that despite an earlier start, better planning and a comprehensive, well-developed output, that is not going to take away the challenges that are undoubtedly going to be faced by staff on the ground, systems as a whole, and of course patients who are part of that process. So I think it's for a whole host of reasons likely to be quite a challenging period over the next few months, exacerbated probably by the industrial action that looks set to continue, whilst we maintain a focus on urgent and emergency care during that. As the winter kicks in and the industrial action is maintained, that will certainly add a further challenge and pressure. So I think, it is, as I say, a comprehensive plan. I don't suggest I go through with my individual points on the 14 areas, because I'll then do a 20 minutes as Jonathan. I think he's done it really well. So I'll leave it at that, Mike, at this point.
Great, thank you for that. So if I can go straight to John to give us any of the latest intelligence around COVID and flu and what we might be able to expect this winter.
So thank you, Mike. So before sort of delving into any of the intelligence, can I just say, when we think about the winter preparations ahead, I just want to thank Jonathan and the team for doing this, and just observe that it's really helpful to see a winter plan which thinks about a community response and builds on some of the learning from last year, particularly around the respiratory hubs, moving them to earlier and being more reactive. And the fact that we've also factored in what we're doing around flu and immunisations going forward. So traditionally, sometimes those preventative measures do get lost, Mike, when we think about sort of big system winter plans, and it's great to see that they're in there. In terms of the winter briefing from Kevin Fenton and his colleagues, I have seen some of the information. It's like anything. If I just take flu first, we are always watching the Southern Hemisphere to see what is happening down there and the patterns of disease. And there is a suggestion that it might have more of an effect on younger cohorts of populations. But it's like anything else. We do have a flu jab. It works really well. And I think there is something for all of us in health and social care, particularly at the provider level, just to think about what we can do to influence our colleagues to do the right thing and have to get certainly the flu vaccine, because there is certainly an element of, dare I say it, understandable fatigue around the whole world of immunisations amongst NHS colleagues, but I think we just need to double down on that from a positive perspective. When it comes to the COVID campaign, there was some movement around the sort of national planning for that, but now we're up and underway in South West London. People understand what they need to do. The new variant is being watched very carefully. There's an awful lot of anecdotal stuff out there, and I'd rather really not dive into it. But just to say that it hasn't gone away, unfortunately, and that the anecdote wouldn't be presenting a good picture in terms of the level of disease and illness. My final comment is that it's not just about flu and COVID. If we remember last year, it was pretty difficult across all of the services, particularly in primary care following the Strep A outbreak. And we've thought about that in terms of how we might respond to that in a slightly different way going forward. However, there was clear evidence that if we were able to encourage more people, particularly younger people and children, to have the flu jab, there is the possibility of some of those infectious diseases actually being reduced at source, which is where we comes around to prevention. And one of the other things, just to say that Oon and the team is watching very closely, is how we're doing with regard to measles immunisations, because I have to say, not having seen a case of measles in a long time, that would be one of my sort of pertinent fears going into the winter. So it's not just about the COVID piece, as I know you well know, Mike, but just to say the immunisations team is thinking about strategically across a broader range of preventable diseases with a suite of flu or sort of immunisations that we have, which are perfectly safe and do work.
John, thank you for that. That's I think that was really helpful. And I think you're right to highlight the community response that we've got and the considerable work around the IMS and VACs. I think that gives the board quite a degree of assurance. I suspect, John, we may well want to come back to this at the November board meeting as we begin to see the early trajectories of infectious disease. If I could go first of all to Annette on primary care, and then I'll ask Nicola to sweep in at the end. But Annette first.
Thanks, Mike. So I think primary care obviously has the same stresses and strains as far as staffing is concerned as all the other parts of the system. But I think that we're certainly in a better position for those practices, and the majority in South West London, I think, are now using the digital tools that we have and being able to triage the demand that we have on the day. And I think that allows us more effectively now to prioritise, hopefully over the coming winter months as well, the appointments that we have, and so give a much better prioritised access to patients while still being able to deal with everyone else's concerns in a more virtual way. I think we talked about, and in the document there is something about respiratory appointments. I think that's a really good idea, but I think we need to be flexible with those appointments, because as John says, if we can get good uptake of vaccinations, and certainly that seems to be the case, we're having really good uptake. We've had our first couple of flu/COVID clinics. Really interested, our population is this year, in getting vaccinated much more than we had thought. And so we're really pleased about that. Really pleased that people are keen to have those vaccinations. Hopefully for children, the uptake will be the same. And therefore we need to use, if we do put some extra capacity in or create some extra capacity, we need to be able to use that flexibly so that we can manage the more general demand over the winter with that capacity as well. I just wanted to draw attention to something called the pneumonia vaccination. And I think it would be really worthwhile us having a look at our pneumonia vaccination uptake amongst the eligible population in South West London. It's really important that people also get the pneumonia vaccination, and that can certainly help us with demand for respiratory illnesses over the winter. So I think that might be something still worthwhile looking at while we've still got some time before the worst of winter hits. But I think overall, with some of the newer tools we have, some of the work we've done well in advance this year, hopefully we're in as good a position as we can be for the winter.
Thank you for that, Annette. And I think really helpful. And I think Jonathan was absolutely right to highlight the fact that the largest part of our urgent response actually happens in primary care. So really good to hear that news, particularly around the IMS and VACs side. Nicola, was there anything that you wanted to add in relation to primary care response?
Yeah, thank you. So I was really struck by slide 6 with that infographic of the wider context, and I think the numbers tell this really important story, don't they? If 700,000 GP appointments a month outweighs everything else by an order or two of magnitude. And that underestimates the actual activity in general practice, because of course not every interaction leads to an appointment. But even if you take that as the basis, then if general practice didn't meet the need or want in just 1 in every 100 patients that then causes them to head to A&E, that would mean there would be 7,000 extra patients every month in our ED departments, 230 a day. And that's needle in a haystack stuff for general practice, but with a potential massive impact on emergency care. So, you know, the board will know that there are many ways that general practice and the wider primary care provision is being strengthened. We heard about it in a previous board meeting. We've got these extra appointments, enhanced hours, we've got at-scale working, we've got additional telephony, we've got big change programmes aimed at reducing the 8 AM rush and building pathways through community pharmacy. But I think what is really important to recognise is that to mitigate the risk of primary care and not just general practice being under such pressure that it can't support the rest of the system. And in terms of Jonathan's question, the critical actions, for general practice, I think this can't just be about increasing capacity, because workforce, estate and IT constraints mean it's just not as simple as that. And it's not really what we do in the next month or so. It's about optimising the way general practice now and in the longer term is able to function in its wider role, so that the element of it that is same-day care is absolutely deliverable in the way that we need it to be.
Thank you for that, Nicola. And yeah, the slide on page 6 is really stark in terms of demonstrating the huge level of activity in primary care. So if we could move on to Jacqueline and SDEC. I suspect you may want to say a little bit about other parts, but I'd be really keen in getting a flavour on SDEC, Jacqueline.
So I think, as Jonathan says, we're the only sector in London where all of us have a 7-day-a-week, 12-hour-a-day or longer SDEC. And I remember when we put it in, which is quite a while ago, it really did revolutionise A&E. But I think we've got to the point now where we need to share best practice. So the stuff around the trusted assessor that I know is Croydon's doing, you know, how can we spread some of that a bit quicker than maybe we are going? Once Croydon have evaluated it, and how do we standardise some of this as well? Because I think that will be a really helpful way of beginning to make sure that we've got all the best practice and we're actually doing all the right things. And I think it will, if we can get to that trusted assessor bit and get some direct referrals in, it will from LAS, it will help LAS so they know that when they come to South West London, doesn't matter where you go, that's how it works. I think some of the also, I think I know the SDEC here at George's will go into A&E and pull, and that's I suppose part of the bit around how are we all doing that? Is that part of the best practice? So I suppose that's all I really wanted to say about SDEC, Mike. It revolutionised A&E, revolutionised the patient experience in emergency care some years ago, and I think we've got an opportunity to make it even better.
Fantastic, thank you for that. If I go to James now on the urgent community response approach.
Thanks, Mike. I mean, I think that we, in terms of the pattern of the data that Jonathan presented, so we know that the overall number of A&E attendances is flat. We also know that the acuity is really significantly going up, and I think UCR has been a key part of making sure that the people that we're seeing are only the people that we really need to see. It does influence the overall mix and acuity in the acute pathway, and we absolutely see that is getting more and more severe every year. And again, we've got a lot to celebrate about UCR. I suppose the question for us is, with the system already being very hot going into winter, how can we maximise really the investment that we've made and the services that we've got? And I think with a view towards some of the things that we see not working perfectly yet, it's about that coordination of care. I think it's about making sure that the pathways into UCR are really clear. And I think it's also about making sure that UCR consistently has the right information to support giving the right care to patients and keeping them in the right place of care. So if patients need to come in, a decision is made quickly, but also that where there is a care plan in place and where there is a really robust support arrangement around a patient so that they can, for example, stay in their own residence or stay in a care home, that information is available to the UCR service so they can be part of delivering on that plan, because we do know that there are still too many cases when we're bringing people into hospital when actually it's probably not the right thing, and we can support them better in their normal place of residence. So I think that getting that consistently is going to be the next area of development for UCR.
James, thank you for that. And I think you're right to highlight the fact that we actually do have really robust systems across Southwest London. This is about ways in which we can improve them. If I could now go to Joe, and I'd be particularly interested in getting a little bit of a flavour around inpatient flow, Joe.
Yeah, thanks, Mike. So I'm sure, as with others, we're working really closely with our partners, particularly in social care, in order to maintain flow throughout the hospital, particularly with timely discharges, and we're focusing on the 10 high impact changes in relation to all of that. First line of defence with all this, and building on what John has said, we're making sure that all of our staff are vaccinated so that we try and avoid peaks of sickness as we get further into winter. And we're also vaccinating our longer staying patients as well. So hopefully that will make it easier for us to discharge them in a timely fashion. I think we've referred to the virtual wards. I think that's a real opportunity for all of us. Although we've, I think, made a pretty good start and inroads into that, there's definitely more we can do, certainly from Kingston's perspective. And then the other thing that we're doing locally is we're also picking up from all of our inpatients, whether they have a carer in support of them, and making sure that we're putting resilience around carers as well, because kind of before you even get to primary care, they're our first line of defence. So there's an important thing, I think, about looking after the carers and building their resilience going into winter. I think the final thing I'd just like to say, which is a bit obvious, but the ongoing waves of industrial action will present challenges to all of us, and particularly we've experienced challenges on our inpatient wards during those periods of industrial action, and that will just be another pressure that we'll have to find our best way through as winter progresses.
Joe, thank you for that. I think that gives a good flavour of some of the things that we're working on. I think you're right again to highlight the virtual wards with 425 beds. That's pretty much the equivalent of a new hospital in Southwest London, if we can get the utilisation rates up and the necessary support around them. Matthew, if I go to you on frailty on the basis is priority 1 in the Croydon Place plan.
Indeed so, and the reason that is, Mike, is because we know that's such a big factor in terms of demand on the service and the impact that has on the population that we serve. I mean, just for very brief points, first is the key to this is preventable care and trying to bring forward interventions to help do that, and there's a whole bunch of mechanisms in place to try to facilitate that. There has been some learning across Southwest London that has supported us on this with the standard approach that is referenced in the slide. I think that's a good thing, but as we know, it also needs to reflect the specific needs of the individual areas, and that's why, as I say, we have it as a top priority for us here in Croydon. I think the development of this into a fully 7-day-a-week service is a positive and should give some assurance to the board and the public that this is something that we know is not confined to a Monday to Friday type issue. It's something that we obviously have to have a focus on consistently, and it's good that we do, and that we are, as Joe's just referenced, utilising remote monitoring to help in this space. We think that's got even more opportunities going forward. We do have to obviously make sure that works with the population that we are serving, and for many people this will be a real positive, but it is not a panacea. There will be some people that monitoring on an ongoing basis is more of a challenge. We're looking now at things like spot monitoring as opposed to continuous monitoring where that's appropriate, and that's a bit more accessible and works with people's lives a bit better. So there's a whole range of things that we're doing to build on the good work that's been done so far on frailty, and that will and must continue because it is such a big part of what exacerbates during winter. It's there all the time, of course, but there's specific reasons why it feels tougher and tighter in the winter in this space, and we will continue to appropriately focus on it going forward.
Thank you, Matthew. And I think you've explained really well what we're trying to do and why it's such a high priority across within Croydon and across Southwest London. Before closing off this section, I will ask Sarah to conclude with some comments around the levels of coordination, the approach we're taking in Southwest London, and the ongoing review and monitoring of the programme so that we can ensure that it continues to meet any new and arising needs. But before that, Jonathan did ask those 3 questions, which was, are these the right critical actions? Is there anything more we could practically do? And as a leadership community, how do we respond and support this programme of work? So really happy to take any contributions on that. And I'm wondering if, I can see Vanessa is coming in, but I was wondering if I could also prompt our non-executive members to consider this in the light of the level of assurance they feel after having had Jonathan's presentation and the comments from different parts. Vanessa, I'm really happy to go to you, and I didn't highlight the work on mental health, but I know it's a key part of our winter planning as well. So Vanessa, over to you.
Thank you, Michael. I won't take long. I suppose on the one hand, so our work is critical, but on the one hand, there is no real winter for mental health. The demand for mental health services has been sustained across the year, but on the other hand, we know that people with mental health conditions are adversely affected by physical health, and their premature mortality is significant. So our role here in support of our partners is absolutely critical. We'll be the first ICS to launch 111 Star 2, which should bring greater parity, and that alongside the 136 hub, which we're also the first to launch, will help us with our response to right care, right person. So I guess I just wanted to highlight we are impacted in and very integral to the work that Jonathan has outlined today.
Thank you for that, Vanessa. Sarah.
Good morning, everyone. I'm Sarah, the Director of the Voluntary Sector Alliance for South West London. I've got 2 points to make, if possible. The first one is I can see the voluntary sector inclusion in the engagement team plan, which is great. What I would be interested in seeing is the inclusion of the voluntary sector in the service delivery budget, which could be around reducing admissions, it could be around all, the preventive. The second point is recognize that this is an NHS board, but I'm really impressed by the planning for winter pressures. And what I was thinking is there scope to bring the planning together with the voluntary sector planning and the local authority planning for winter to the ICP?
Thank you for that, Sarah. And they're both really good points, and I'm sure that we can ask Jonathan to reflect on whether there's scope to use the voluntary sector more. Clearly, they have been heavily engaged and continue to be in our immunisations and vaccinations programme, and also in terms of our community response, in terms of some of the support that's provided directly to keep people in their homes and support them to stay independent in their homes, but all very, very vital points Zara. I'll go to Ruth.
Thanks, Mike. So my name is Ruth Bailey. I'm a non-executive member of the board. So I think just echoing what others have said about, I think this is a more robust plan than we have seen from last year. So thank you for all the work that's gone into that. And it's really good to hear the reassurance that has been added by different members of the board. The one area where it felt to me that there was scope for ensuring we're doing as much as we possibly can is on the cultural change that impacts on the discharging and virtual wards. It, you know, from all the statistics and from the specific slides on those, it does feel that that's the area where there is capacity that is untapped and unused. And so a real strong focus on the cultural change, as you've mentioned, I think is essential to really making best use of it.
Thank you, Ruth. And I suspect Jonathan and Sarah will want to comment on that as we sort of conclude this session. If I could go to James next.
Thank you. So probably 2 points. I think the first is in response to the point that was just made about the voluntary sector involvement. I think that in terms of how we work that through, I think that place has a really important role to play. I think if we look at the sort of what the voluntary sector really bring, which I think is sort of unique. I think it's the localism. I think it's the ability to focus on particular challenges in particular communities. And I think this is where using our places, and you know, the urgent and emergency care boards are very much based around the places, and bringing the voluntary sector in that way. I think if there is the opportunity to do more things consistently at scale, then I think we should explore that. But I think that, you know, experience for me would be that is the level at which that is sometimes is best organised, and it's important that we have them around that table. I think the other thing that I just wanted to highlight, and Jonathan briefly alluded to some changes in policing that we know are going to affect our emergency care later in the year, is just to note that I think that's one of the things that we will need to keep a really close eye on as a leadership community. And Vanessa's highlighted, you know, many of the sort of simultaneous pressures we'll have around mental health flows. I think that the reality in a busy emergency department is that, you know, sometimes the number of mental health presentations are such that the mental health emergency flow and the physical health flow are occupying the same physical space and competing for the same physical space and for the same resources in terms of staffing. And I think that's a relatively new phenomenon for us. And I think it's just, you know, in terms of some of the key challenges that I think we'll need to keep an eye on through the winter, I would highlight that as being one that's sort of towards the top of my list of concerns.
Thank you for that, James. Mark.
So firstly, thank you to Jonathan, because it really shows the breadth of what's going on. But the point I just wanted to raise is I agree with James around the voluntary sector in place. But one of the things we are finding at place as well is just about each sector knowing what is available in other sectors. And if we use two examples of that, one is the primary care hubs, where they are when they're open, and then what's available in the voluntary sector to support people to stay in the community healthy. So there is a relatively simple what can we do, and that's to make sure we know what services are out there to support people not coming into hospital in the first place, and then when they're discharged, staying well at home. So I think that's one of the actions.
Mark, I think that is really sensible. I know that it can be really difficult. People don't anticipate they need to know anything until they need to know something, and then it's sometimes very difficult to find out what's there. So if I go to Karen next.
Thank you, Chair. I was just going to give a couple of examples on kind of cultural change and changes in virtual ward, just to assure board, as Ruth raised, that those things are being taken forward as well. So just to mention Central London Community Healthcare in St George's, we have dedicated in-reach clinicians that join St George's ward rounds on a daily basis to support those people that are appropriate for transferring to virtual wards. that piece of work is enhanced by a Darcy Fellow who works with one of the medical consultants on the a change in education programme on behalf of both organisations, so that within the trust the awareness of virtual wards is raised, the referral process is simplified, and we try and get that clinical change kind of more embedded than we see it today. With Kingston Richmond, Joe mentioned Kingston Richmond, and partners there are developing a kind of a step-up model of care. So really having a clinically led conversation about how to take the model that is currently in place, but actually make it much more appropriate to Kingston and Richmond. So designing with clinicians so that clinical change, I suppose, is embedded from the beginning. And then in Croydon, I suppose it's as much about culture change as system change. So in Croydon, we are piloting a data algorithm that will use patient data and identify those who potentially are available for and right for virtual wards. It currently is being looked at, but the idea is that the piloting of the software tool will allow discharge software to independently identify those patients who meet the criteria for discharge into a virtual ward, and will flag those to clinicians rather than clinicians having to do that work themselves. So a combination of using digitalisation to enable clinical change, clinicians designing pathways and services and initiatives with us, but also then looking at how you change clinical practice right in hospitals as well. So a whole range of things that are going on in order to make that change kind of be embedded.
Karen, thank you for that. And there were three really, really rich examples of work underway. I think the one in Croydon sounds actually really, really exciting in terms of supporting clinicians in order that they can make their decisions much, much more quickly and appropriately. If I go to Elisa next, please.
Thanks, Mike. I just had a couple of questions. So HealthWatch is very eager to help with communications around different behaviors the public should take in order to reduce the burden on the health system. Just a question about the behavioral change initiative. I see a lot of emphasis in terms of disease prevention around vaccinations, but are we also going to be promoting masking and social distancing again, or has that been abandoned in terms of communications? And the other thing I just wanted to note is that HealthWatch in Croydon, Merton, and Wandsworth, we're undertaking a joint project with the Health Innovation Network around virtual wards, specifically to understand why people who are eligible are not taking their place. We know that there might be problems actually accessing those people who've been invited to use a virtual ward, and so we're developing proxy groups of patients who we might approach, and it'd be really helpful for us to know if there are any kind of generalizable characteristics of people who are not taking up the opportunity to go into a virtual ward. I don't know if anybody in the call might know that. Thank you.
Thank you. Really, both really interesting points, and I think the piece of work that you highlighted around public resistance is a really useful one. I'm sure Charlotte will have some comments on both of those points, and I'll bring her in a moment. Sarah, if I could go to you, and then I'll go to Charlotte, Jonathan, to any final comments, and pass across to Sarah for the final assurance piece around coordination and ongoing review.
Thank you. Just wanted to thank James and Mark for their contribution, and the fact wanted to add that the Alliance is really interested in any collaboration. So please get in contact. We have voluntary sector umbrella organizations at each place, and they really know what there is for the voluntary sector, and we can collaborate to make sure that we know what there is out there and people can access it. And the same for James, kind of looking at place maybe and participation of the sector on any boards. I would be really interested in getting involved.
Thank you, Sarah. Thank you for that offer as well. I'm sure people will respond positively. Charlotte.
Yeah, no, I just wanted to say thank you to Alyssa for Healthwatch's support around the behaviour change, because and you are very right, it's not just about vaccinations, and of course they're really important, but also around signposting people to the right care at the right time. And I suppose I just want to highlight the work that the voluntary sector are doing for us with very small grants, as Sarah mentioned in the pack, you can see there. So very small grants of kind of £200, where we are coming together with community organisations to bring together local people in an informal setting, so hosted by the voluntary sector, to talk about NHS services and how to get yourself vaccinated, how to use 111 either online or on the phone, and with examples such as, so in Merton we had the Ethnic Minority Centre ran a knitting session and hosted conversations. Another organisation ran kind of walking outings, supported with befrienders and giving people a chance to connect. In Sutton, we had the Riverside Community Association ran a Warm and Well Tuesdays for people just to come together and hear about services and how to use them in the right way. So that in a way is great, because it's supporting our voluntary sector and building our community resilience and communicating with our grassroots communities, many of whom aren't online. So obviously we do a lot of work in the digital sphere around signposting, but really getting into our grassroots communities and targeting that work where we know we have high attendance of use of emergency care services. So thanks for that, Alyssa.
Thank you, Charlotte. Jonathan, I said any final words. You can see there's a lot of energy on the call in relation to this program of work, and many of the people on the board have actually been involved in different component parts of it. Did you get what you needed from today, Jonathan?
Well, in a word, yes, and in a couple of words, thank you for everyone's support and energy and enthusiasm for this. Just if I might just do a couple of comments to Sarah's questions about the link to the voluntary community sector. There should be plans really embedded at each local A&E delivery board linked to the Adult Social Care Discharge Fund. Around that, I know James has alluded to that, but I think that would be where you might see some of the detail that you're looking for. But there are also initiatives at scale. So, for example, the London Lifesavers stuff that the ambulance service is doing around ensuring people can do CPR, involving volunteers. So if you want to talk to us outside, very happy to talk about some of those. But I think a lot of it you'll see locally in local plans. And I thought Karen gave some really good examples of the sort of cultural change piece that we need to drive. And I think it is a bit like painting the Forth Road Bridge, isn't it? But the discharge and flow piece is something, one of the other areas we need to keep really focused on, both in the short term through the coming weeks and months, but also thinking about what our plans look like for the following winter, because I've taken license to press ahead early for next year's winter plan, Mike, from a lot of what I've heard. And I think that's going to be a real area that we need to sort of get on with and grapple, so that our plans for next winter are strong and reflect the learning from this. But thanks for everyone's support and commitment, and thanks for all your teams are doing to help us through the next 6 months. And I'll pause there, Mike.
Jonathan, thank you very much. So final words across to Sarah.
Yeah, I'm going to just mention a couple of things. One is, please do look at the wider communications and engagement work that we do in South West London. We've got a lot of experience of this, and actually we've done a lot of learning, and I think our approach is very positive. So, you know, there were slides in the pack, please do look at that. We will be bringing back in the November board the primary care access plan, so I think that's quite important. So we talked about some of the key parts of that plan when we talked about primary care, but that is coming back for a wider discussion at the next board. On the governance and how we oversee this, we have a number of ways, but we on the day-to-day management, we have the System Control Centre, which we have learned a huge amount during COVID, and we, as a Category 1 responder now in the ICB, we have set up new systems and processes to make sure that we have daily, hourly, however often it's needed, coordination up to 24 hours a day, depending on what the need is. So we have that kind of daily operational system control centre coordination type role in South West London, and we work really closely with all of the providers across the system, including other parts of London as well, LAS and the region. On the oversight of the plans, we have a South West London Urgent Emergency Care Delivery Board, which is jointly chaired by Jonathan and Matthew, and they will be monitoring the delivery of that, but also, as we did last year, doing a kind of wrap-up review of things as we in an ongoing basis throughout the winter, but also at the end of the winter we generally do a kind of review of how it's gone and what the learning was to learn for the next lot. A couple of things I can just say, Mike, is, you know, winter is all year long nowadays. So we have this winter plan, but actually it's a plan for the year, I think. And what I would also say is that people have put a huge amount of effort into this. That's really, really clear. And there's loads of work, and we are doing some really good stuff in South West London. But there are so many unknowns that we just cannot control. Industrial action being one we've talked about. We've talked about the impacts of COVID on, you know, the weather in the winter, all of those things. We do as much as we possibly can to mitigate against those things, but we cannot absolutely guarantee always that we will be able to control everything that's going on. So I just think it's really important that we know that we are as prepared as we possibly can be, but there are so many unknowns around this that we still hold risk within the system, and that we need to recognise that, and we will continually update the board on where we are on that.
Sarah, thank you for that. And I think you've given us a good conclusion to that section. We note the report, we note the level of assurance provided in the plan and the collective work that's been done. And again, just a big thank you to everybody for what I know is a huge amount of work in terms of planning, but it's even bigger amount of work in terms of delivery. So the next 6 months will be tough. Moving on to item 7, I'm going to ask Vanessa to speak to this. So this is children and young people's mental health and emotional well-being update.
Thank you, Chair. I'm going to present my slides to help people work through the pack, but just for orientation, it runs from page 56 of the pack. So I'm joined today by John Atherton, the Director of Mental Health Transformation at the ICS, and it has been great to have both Ian Dodds and Mike Jackson's input into today's pack to ensure that the social care partners are involved. I recognise that there's a lot of detail in here. There's lots of activity and significant interest in the children and young people's mental health area. Co-production is absolutely central and key to the involvement of getting things better. We know, and people tell us, that children and mental health services are complex to access and navigate, and it's very difficult. We also know that it's highly emotional and emotive. There is nothing, I think, that has a greater impact than sitting in front of a child and then telling you that they no longer want to live. And it's in that context I provide the update. The pack contains a summary of, I need to move it on. The pack contains a summary and the ICB is asked to do 2 things today: to approve the updated South West London Child and Adolescent Mental Health Transformation Plan. This is an annual update and is against the national requirement. There are 90 key lines of inquiry within that national inquiry, and therefore this is only a small part of what we're doing, but a very significant part. And as a standalone document, it doesn't add up to all we need to do. So the second ask of the board today is to receive a wider update of the CAMS transformation work that we're doing. The service demand is significant. So CYP mental health was projected to grow by 2% from 2018 to 2021. But in reality, the overall service demand has increased by 11%, and that demand is sustained. Referrals to CYP mental health services have increased year on year since 2021, and 4.5% of children and young people receive community NHS funded mental health treatment in South West London, and this is above the London average of 4.1%. Young people admitted to hospital because of self-harming behaviours is higher than the London average in Kingston, Richmond, Sutton and Wandsworth. Provision is complex across our services, and prevalence is also high. In terms of our finances, 32.8 million is funded from the ICB baseline allocation to children's mental health services. This represents 10% of the total spend on mental health services, which is just 10% of the total spend against the total health spend. We have a number of plans. So first off, the CAMS transformation plan sets out the vision, priorities and actions to address the emotional well-being of mental health needs in CYP, plus their parents and carers. But we also have 3 other plans across our ICS that address and seek to improve access and outcomes for CYP, and I just wanted to work us through those. The mental health strategy, which the board approved in May 2023, sets out our agreed focused ambition for CYP. The joint forward plan sets out how the ICB will deliver ambitions for mental health and respond to the needs of our people and communities. And then we have our integrated care partnership strategy, which focuses on positive mental health and well-being, particularly of CYP, and with a very strong focus on prevention, which is absolutely critical if we're going to achieve better health for our population. The next 2 slides talk about how our plans develop, but I will skip through those. But suffice to say that there has been significant co-production with over 700 people involved in the development of the mental health strategy. We have a clear set of priorities, which are outlined on the following 2 slides, one against the mental health strategy and one against the partnership strategy, with the focus on, as I've already said, prevention. We also have the development of the provider collaborative, and the board has agreed that the development of a case for change is already underway in relation to the provider collaborative, and this proposal will seek to reduce the variation, improve the outcomes and connect together the wider highly specialised services in Tier 4 alongside the locally commissioned services. We have a clear set of governance arrangements in place to monitor both the delivery of the plan and the outcomes of the plan, and that's outlined on this slide here. I wasn't intending to go any further into the detail of the CAMS transformation, because I know that people will have had chance to look and ask around that, but I was going to pause there and open to any questions.
Thank you, Vanessa. And I think it was a stark reminder that just 1% of our total NHS spend is dedicated to children and young people's mental health. It is a priority for us within South West London, and I think it's useful to see the work that we're committing to on transformation. If I can go to James next.
So thank you, Vanessa, and really helpful walkthrough. From a Sutton perspective, one of our concerns for some time has been the growth in children who have both autism and a learning disability and associated behaviour that challenges. And I think the move towards the key worker programme and also the institutional more positive behavioural support linking into the dynamic support registers is a really positive development in this area. I suppose that my question is whether we think that we firstly right-sized the sort of infrastructure mechanisms, which is what they basically are, and what it might mean for the sort of market that we need to create and the provision that we need to create for support for those children. Because I think as we as we start to put that support around, as we start to identify those needs, what we're going to find is that there will be sort of a greater need that will start to become more apparent to us.
If I could, we'll take the questions. Yeah, we can come back to you. If I go to Charlotte next, but I'd be really keen to hear from Ian. Oh, Ian, you just put your hand up. Perfect timing. So I can go to Charlotte first, and then we'll go to across to Ian.
No, I just wanted to highlight the excellent work that the Mental Health Provider Collaborative does in kind of co-production and co-design and talking to young people. And I suppose I just want to say that that is difficult to do with children, young people with mental health issues. And I think there's a lot behind those, the kind of top level, high level themes that have come back from young people. And I just wanted to say there is a lot behind that, where I know providers have gone and talked to children and young people. The mental health strategy did a whole load of engagement work, and I think I just wanted to highlight how good that is and how we can all learn from how you've done that. And I know that there's a lot more information that we can access and put into a South West London, if you like, pot, so that everyone can kind of access it. But I just wanted to say that.
Thank you, Charlotte. I think really right to highlight that work, and I think particularly our Children's Mental Health Service approach is showcasing the sort of work we ought to be doing in all areas around co-production. If I go to Ian next, and of course Ian, as well as being the place member for Richmond, has a day job as Director of Children's Services. So Ian, I think your perspective here, our local authority partners are key in this space.
Yeah, thanks, Mike. So first of all, just to thank Vanessa, because she has taken a really co-productive approach to this, and that is greatly valued by me and my DCS colleagues. So thank you for that. And you know, Vanessa's right to highlight that we are seeing a significant increase in need, both in terms of the number of referrals, but also in terms of the complexity or acuity of need. And that is placing significant pressure, I know, on all mental health services, but also on children and social care services as well. And Vanessa's also said that the landscape is incredibly complex. I would agree with that. And it's, I think, made more complex because of the differential levels of provision across the different places. And I think that is something that we're going to have to both acknowledge and address. So, for example, you know, a child in Richmond will wait significantly longer for an appointment than a child in Merton, for example. And so we're going to have to look at how we address those issues. I know that's tricky, but you know, that's what we're in the game of, isn't it?
That's a really good point, Ian. Thank you for that. I'd go to Zara.
Hi. I've got a couple of points. One is on mental health in schools. I understand it's a mixed picture across South West London. We've got Kingston and Richmond, you know, having, you know, good coverage of the public schools, but Croydon currently has a 30% coverage, with Merton and Sutton somewhere in between. So I would like to know what, you know, what the plans are for a borough like Croydon. When it comes to mental health in schools. The other comment I would make is following from what Ian said as well. I appreciate that from my voluntary sector colleagues that there are different, you know, levels of support in different places, and what are we going to do about that? And thirdly, just an invite really, we decided as a leadership group of the Alliance that one of our priorities will be mental health. And so that will be one of our work streams for this year. And so it really an invite to get in contact and collaborate with us going forward.
Thank you for that. Vanessa, do you want to take those points, and we'll see if there's any more points. Before that, it might be worth just flagging up the fact that, you know, you did highlight that just 1% of the budget is spent on children's and young people's mental health. We have made a firm commitment to increase the overall proportion of funding going to mental health services to bring us closer in line with the national average. Sarah or Helen might want to comment on how that might help us improve our investment levels in children's and young people's mental health services as we make that shift over time. But Vanessa, do you want to pick up on the other points?
Yeah, absolutely. So I'll pick up on James's point first around neurodiversity, which I think is really really critical. I think we have we're doing mapping across around what the level of need is and how we address that level of need. The complexity of CAMS around the support to the family, the support to the schools, the support to the young people, and the multiple agencies at play is significant. When you have just one diagnosis, when you have multiple diagnoses, that becomes even more complex. And I think that's, James, is what you're appropriately highlighting. So I think it really is about how we work at both system and at borough level to ensure those needs are addressed. And I don't think that's going to be a quick one to do. Equally, it's about how do we support all sectors to be connected together to meet those needs. Mental health is a priority for everybody at the moment, which is great. And with that, we have to be very thoughtful about how do we channel our energies to the areas where they have the most impact. And I think if we can stay aligned to the priority areas that we as an ICB board and the ICP have set, we stand a much better chance of delivering against those, which kind of picks up again, Sarah, your point around mental health in schools. So I talked about how we make decisions around how funding is distributed. So historically, that went the funding and the resource was prioritised on weighted population. And the commitment that the ICB has made is that we will prioritise it on need as well, and we're doing that through the planning round, and the mental health schools transformation programme will be led out of that. Equally, that will happen at both system and at borough and place level, and it's about how we maintain that connection. I think in our ICB, we've got off to a very strong start with our mental health partnership delivery group, and I know that we have colleagues from the voluntary sector on that group that are helping us to direct and work and energy. And I don't underestimate the scale of the challenge. We have some significant work to do, and resourcing is not just about money. Resourcing is about directing people, our energy into the right areas, in those areas where it makes most impact. So I haven't come here today to plead for more money on its own. I think it's about us collectively as a board agreeing our priorities and agreeing how we spend our time and attention, energy and resource in its totality.
Yes, thank you for those really thoughtful responses. Before going to Sarah for sort of final comments on this, Helen, did you want to come in on anything in relation to any medium-term thinking around our financial strategy to support children's and young people's mental health services?
Thank you, Chair. So I think we're undertaking a piece of work in the background with Vanessa and others around what would that look like and how could we do that. So as we go forward, recognising the financial context we find ourselves in at the moment and the rules that we need to work to with NHS England, what we want to be is in a really good place to be able to have those plans in place to action them as soon as those rules are lifted from us.
Thank you. Sarah, over to you for final words.
Yeah, I'm going to be a bit more pushy than Helen on that one. I know she expect me to. So firstly, can I just say something on need? I do think we do need to be careful about need, because if you look at the paperwork, and I did, you will see that the prevalence that would be expected of mental health children would be the highest in Croydon, and yet those are not the people that are in the system. So what we need to be very careful about is conflating need with waiting lists and those that are accessing services. We have a huge unmet need as well of young people who are not even getting access to services or do not know about services. So we kind of need to address, when we talk about need, we need to be very careful, but we need to address that unmet need as well as the need that we know about that is already on waiting lists and so on. So that's the first thing I was going to say. The second thing I was going to say is this is obviously a priority for us in South West London. It is obviously an area of increased demand, and also, rather, I'm not going to break into song, but children are our future, aren't they? And actually we do need to make sure that that we address some of these, particularly these mental health issues that have come to the fore during COVID and have really now, I think, coming out of COVID, I mean, surprised us, I think, to some extent, how much this has impacted on the system. And when I say that surprised us to some extent, I would say, let's not expect this to improve overnight, because I think there's a huge amount of work to be done to help this to improve, because it will be, as Vanessa said, it will be resource in terms of money, but it'll also be, have we got the staff? How do we access this? What's the different types of ways of dealing with it? Some of it is quite new. We don't yet fully understand, I think. So so I think we're on it in South West London and we want to make the difference, but there's still, I think, work to be done for us to get to the end point of outcomes. And then on the money, what I will say is that it's our intent to bring back a paper to the November board to talk about, in principle, how we shift monies to mental health and community. I think that I would really like the board to support us in trying to do that. It may well be, we do have to obviously follow the regulations, as Helen said, and it might be a timing issue, but I think we need to get that in principle agreement from the board that that's where we need to increase our resourcing in South West London. So I'd like to bring something back in November for discussion, for an in principle discussion with the board, so that pre-planning, so that we can start to think about how much of that can we do as quickly as possible, how much of it do we have to wait for agreement for nationally. But I do think we ought to, at least as a board, sign up to that. There we go.
Sarah, thank you for that. And the final point I think is really important, and I'm really pleased we're bringing that to November. I think we do need to have an in principle decision around that commitment, both around mental health, but also in terms of shifting our spend upstream to more preventative areas, into primary care and community. I think your other point, Sarah, is really, really important. I think it's a message across the whole service. We have to be really careful not to use captured demand statistics as a proxy for need. If the only data we have is on the demand for services, we should call it demand. We shouldn't call it need. It is not need, and we will continue to reinforce our spending against principles of tackling health inequalities if we purely follow demand. So really, really important to highlight that point. We're going to take one final item before we have a 10-minute break. In providing this to Jonathan and Karen, just remember you're keeping everybody from a cup of coffee. You have up to 10 minutes.
Thank you very much, and noted. I think we'll be brief. Just to say a couple of things by way of introduction. So the board in its May meeting has already looked at delivery agreements, partnership delivery agreements. Those were for place. We know that shadow arrangements for place were put in operation in kind of 22, 23. And actually, when we've looked at the provider collaborative arrangements, we've used that learning to develop provider partnership agreements for our collaboratives. The purpose of them is to describe the responsibilities that the board is delegating, that wants to deliver by the provider collaboratives. And just reminding people, we have three. We have the acute provider collaborative, we have the mental health provider collaborative in South London Partnership, and we have the cancer collaborative of the Royal Marsden Partners. They are not legally binding documents, neither are they delivery plans. They are intended to be high-level documents that have information within them that is consistent across the provider collaboratives, but also recognises the differences that they have. So Although we have a standard set here, they are different because of that. This is the first year that we've produced these for the collaboratives, and as they develop and as the ICB develops, I'm sure we'll want to have a look at those and improve upon them. I would just say that when I looked again at the mental health agreement, I think this version doesn't have the finance delegation, which is what the board agreed in its March meeting, which I will amend and send round if that is okay. Jonathan, before we ask the board for recommendations, is there anything that you want to mention on either the RMP or the acute provider collaborative agreement?
Thanks, Karen. Two very brief points, given the time slot. One is just to flag they haven't yet been through all trust boards, and that was flagged. So that will happen, I'm sure, through September and October. But given we're halfway through the year they relate to, we wanted to get on with implementing this. And second, for me, what the core purpose of these is being clear about what provider collaboratives are and aren't going to do. And I think there's been an awful lot of work from teams across the ICB and with the 3 provider collaboratives to get them into this place. And I hope it does help us. We will iterate them going forward, but be clear about what provider collaboratives are going to do across the system and where the individual responsibility remains with trusts or the ICB or someone else. So that just for people who had to wade through the long papers, that's what I thought the purpose of them was. And I'll stop there. Thank you.
Thank you. So then, Chair, just to ask the board then to approve the provider collaborative partnership delivery agreements, but recognising, as Jonathan just said, that they also need to go through governance within some of the trusts. And also, as we've said, these will be developing documents. We're also asking the board to agree that any future changes to the document are delegated to the senior management team to put in place, unless it's a material change, in which case we would bring it back to the board. Thank you.
That all sounds sensible. Before I ask the board to provide their assent to that, Jacqueline, my understanding is you're still the SRO for the acute provider collaborative within the collaborative. Any comments that you'd like to make before I ask the board to consider the recommendations from Karen?
No, this is something we've had for quite a while, and we've refreshed it, I think, just to make that point as well. So we've updated it. So it's an updated version of something we signed some years ago. So we are happy to support it.
Excellent, thank you. On that basis, can I assume my board colleagues are happy to support this document and the recommendation that any future non-substantive changes to the document will be made by the senior management team rather than brought through the board? I can see no dissent, in which case I think people probably want to have that 10-minute break, so we will do that. Karen, Jonathan, thank you for keeping that item brief. It is important, but I know that it has gone through a lot of discussion previously. So thank you all very much. We will reconvene at 11:45. Welcome back, everybody. It's good to see everybody is punctual and back at 1:45. We're going to move on to item 9 on the agenda now, and Helen is going to give us an update, mid-year progress update on our green plan. So Helen, over to you.
Thank you, Chair. So as you'll remember, we signed off our green plan for the next 2 years earlier in this year, which had 10 work streams within it. And this is just a short update of where we've got to as mid-year progress, as we're about to report back to NHS England as well around the journey. So some things just to highlight within it. We've made progress on all work streams, but some particular items, the fact that we've responded as a healthcare system to the Mayor's Climate Resilience Review, and also actively participated in the workshops, and I've started to develop relationships with the team over there, and they're looking to work with us in South West London to try and progress some adaptation work around what that could be. So we're looking forward to continuing to develop those relationships and build on them as we go forwards. We've been focusing on primary care. That was one of the key discussions we had at the board previously, that we were quite well developed within the trusts and the hospitals, and taking stuff forward and understanding their carbon footprint, but actually we're less so in primary care. And so we've continued to develop that. At the moment, we're working on how to develop some champions across the system so that we can get more engagement across the whole system. But a key piece of work we're doing with the regional team at NHS England is around identifying the carbon footprint for primary care, and how to do that and assess it, which is quite complicated because obviously the estate varies significantly between the different facilities that we have. But we look forward to bringing some more work back on that as we go forwards. And we're continuing to work on our carbon footprint as part of our data work stream as we go forwards. And also we've been looking to strengthen our relationships with local authorities. So we have got representation within our sustainability leads group from local authority areas, and their helpful input is absolutely brilliant in helping us go forwards and learning from each other. We've attended the Director of Public Health meetings and been part of discussions about how can we take things forward. And I think education of the public came up as a really key item in all of that, and we're looking forward to how we could work more closely with our local authority colleagues on that as we go forward. And I think then there's something about how do we further involve, say, the voluntary sector and Health Watch and others in those discussions as we go forwards, because you've all got key contacts with the population, and actually how do we therefore embrace that communication and education in what we do and how we take things forward. We've been very successful in getting some small grants in from Salix around how to develop business cases for decarbonisation, and so we'll continue to look to do that and learn, and we've held workshops to spread the learning for those that have put bids in for them, to actually help other providers to be able to bid as we go forwards. And finally, in the back of the pack, I included another case study, because I think the other ones that we talked about earlier in the year were really helpful to bring alive the agenda and what's been achieved. And what we did in 22-23 was we created an innovative fund for developments to support sustainability from part of the trust funding that we already had. And so we used that, and then within that we there was a successful bid for smart theatres at the St George's site. So this is about using sensors and monitors within the theatres to actively help and support. And so this is just an update on that project, which I think has been highlighted as an excellent project, and is going to be highlighted by the Future Hospital Programme up to the ministers as a great initiative. So theatres are the most energy hungry part of a hospital, and I've been told that one operation is equivalent to driving a petrol car 450 miles, which sounds like quite a lot of carbon emissions as we go forwards. And this project was developed by the Clinical Reference Group at St George's, supported by the Estates Department and the Medical Engineering Department. And although its focus was about how do we reduce the energy usage and get the carbon emissions down, actually I think the clinicians were really engaged and wanted to support how could we improve the experience for staff and patients as we go forward. So how do we have less cancellations, less DNAs? How can we support patients to have safer environment to be able to be treated within? Because the idea was that if you've got the theatre is either too hot or too cold, then actually that could stop the surgery from happening. If the circulation of the air isn't correct, then obviously that could impact on infection control, etc. And so key to all of this was, how did we get proactive rather than being reactive in what we were doing here? And so these sensors were retrofitted into the theatres to be able to have real-time live dashboards to be able to follow what was actually happening. And what they've seen is a significant reduction in energy uses, especially when the theatres are in downtime. So by having ability to switch off the lights, etc. But also to be able to monitor all of the equipment within the theatres, so that actually we can be proactive about when we need to do the maintenance on what we're doing, because we're knowing how often we're using them and how when they're getting towards their end of life, rather than reactively waiting for a piece of kit to fail and then have to maintain it and replace it. So actually I think there's some really exciting stuff in here again that we're doing within South West London, and I look forward to updating again in future. I don't know, Jacqueline, whether or not you'd like to add anything from your perspective on that project as well.
I think the key is what you said, is having a few enthusiasts about this and supporting them to really go the extra mile in trying to reduce carbon emissions. And it's been really good to see that that's also spread around use of public transport and bicycles, and it's a lot easier in St George's probably because we've got so much better links around transport. But you know, we've had to double the amount of bicycle sheds that we've had and increase the showers because more and more staff, particularly with better road safety, are actually using it. So all of this is really good stuff, and I was really amazed when they started telling me a few years ago about how much emission just from some anaesthetics drugs. There's a lot you can do without spending that much or any money to reduce your carbon emission. And I think if you talk to Emma Evans, who's been leading this and is actually the clinical lead for South West London, she would give you a host of things that we could all do that actually just reduce carbon emissions and don't need. This is going the extra mile in theatres, but there's lots you can do by just changing how you practice.
Thank you for that. Helen, thank you for the update. It's really encouraging to see. I'll come to Ruth in a moment, but I just thought it was worth highlighting that I know there are significant challenges on our estates because of the varying ages and the varying quality of estate, but we do have a particular showcase in South West London, which is Springfield, which shows us how you can do it and create a not just a sustainable environment, but a truly fantastic one, which I'm sure has therapeutic value and must be great for staff to work in. I also would be quite interested to check that we are embedding green into our other transformation plans. So clearly looking at things like outpatient transformation, we know that 24% of all journeys in London are NHS related. About 8% of those are our staff getting to work, but the rest are patient journeys. And so around 16% of all journeys in London are people coming to and from appointments at hospitals, in GP practices, etc. Clearly, the more we can do to reduce face-to-face appointments in outpatients, but also in terms of clustering appointments where people have multiple tests to do, that isn't only just good for the patient in terms of convenience, but it actually reduces carbon footprint. So it would be good to get some assurance in relation to that, and in relation to some of the other things like car loan schemes, whether or not they are exclusively EV now, as opposed to still continuing to support people to purchase petrol vehicles. So there are plenty of spaces in addition to the detailed programme where we could be making a difference. If I could go to Ruth first.
Thanks, Mike. And just a quick point in the spirit of partnership, really interested to hear about the smart theatres. I know in social care, we're thinking more and more about how we can use tech and digital tech to improve services, to make sure that people have better access to services, but also to reduce our carbon footprint. And I just wanted to check that the people that are leading on the smart theatres work and similar sort of work are also tied into the South London Partnership, because we're leading on a scheme called Innovate. And here's the good news: there is funding available from both the Mayor of London and from London councils to think about how we can use digital technology better. So I just want to check that we are joined up on that, because if we can introduce some of the work that you're doing, I don't want to slow you down, but if we can introduce some of that work and tie it up, I think we'll have access to even more funding, and that could get really exciting. Thanks, Mike.
Thank you for that, Ruth, and I'm sure Helen will come back on that. James.
So, I mean, I think it's probably worth highlighting at this point the Building New Future Hospitals programme, where ESTH has a scheme as part of the National New Hospitals programme. There's a couple of things to highlight. The first is that all NHP schemes will be net zero, and that will be embedded into the construction techniques and the use of modular construction through the national methodology of Hospital 2.0. As Ruth knows, we are really keen to look at how we can, with partners in the London Borough of Sutton and the Marsden Institute of Cancer Research, look to build as sustainable and greener transport and access policy as possible, making sure that when people do need to get to the hospital, they can, but we try and build that sense of place and a sustainable transport strategy around place. I think the other thing to highlight, and I think as there's clinically and operationally more and more pressure to consolidate services, I think one of the real attributes of the BYFH scheme is that it actually retains 85% of patient contacts at both Epsom and St Heliers sites, and only consolidates the 15% of patient care that we know needs to be done 24/7 in a new building. So I think that there's opportunities within our existing schemes to make sure that they are looking for as many opportunities as possible to embed that sustainable approach.
Thank you. Joe.
Yeah, thanks, Mike. And just I chair the South of London Outpatient Transformation Board. So just in terms of the assurance that you're looking for, in all the plans that we're developing, you'll be aware, in line with the national imperatives, we're trying to reduce the number of inappropriate appointments. We're trying to reduce the number of follow-ups where they're not necessary. And in our work, as you have mentioned, we're also looking to see whether we can cluster appointments to reduce journey times. And in addition, we're also considering where there are different settings which may reduce congestion on some of our busier sites. I think we've got quite a long way yet to travel. I think we're sort of in the foothills in terms of what digital transformation might mean for us, and we've been successful in securing 2.1 million of investment in digital technology, which will really help us as a programme, but I'm sure there's far more that we can do. And then in addition to that, I've asked that anything that we do and any programmes we consider, we must, as part of that, consider the impact on the carbon footprint of the services that we're talking about. So that is now being hardwired into all the work that we're doing.
That's fantastic, Joe. I think that will make a major difference. It's great to have a sort of a dedicated program of work, but actually if it becomes business as usual, that's where we'll make the real changes. If I could come to Dick next.
Thanks, Mike. I think you, James, and Joe may have covered some of what I wanted to say. Really important that this that the green strategy actually reinforces and accelerates our wider health strategies. And I think the issues about care pathway reform are a good example of that. And what you said about transport, actually, it's often the case that better care, empowering patients and actually shifting care to where it should be, also is a powerful driver of the contribution we can make on green. And that issue of our estates and the quality of estates, I certainly know in local government over the last decade, improving estates has been a very effective way of reducing the need, the amount of heat that's lost through buildings, because improved buildings are better insulated. Now, I know we've got really complicated systems for investment in capital hospitals, primary care as well, but it's worth us thinking about what good would look like and building that in. And both these are examples of how a green plan shouldn't be a separate good thing to do. It should be something that actually accelerates our core health strategy for transformation, contributes to the sort of transformation in the financial recovery plan, for instance. Cheers.
No, thank you, Dick. Really, really well said. Matthew.
Thanks, Mike. Yeah, and not down the outpatient or theatre line, but just another example of what we're doing in South West London. We've got a significant bid in that Helen and the team are supporting us on through Salix on a new heating approach in Croydon, and we are very optimistic. This is the second time round we've been in this process. We got some good feedback, although not success on the first round with Salix, but we're hoping this time we're having got the lessons from that first application and some changes made to it in the second version that will be successful. Obviously, we're competing against others across the country, so but just to keep the board informed that there is work in that space also going on this agenda.
Thank you, Matthew. That's a really helpful update. Vanessa.
Obviously, we've been very lucky at Springfield to have the ICS's support for the transformation, but I just thought it was worth sharing some early facts, not just about green data, but also about the patient safety and staff safety impact. So in the first 6 months, we've seen a 36% reduction in patient safety incidents as a result of the new environments. That means that people will be with us for less time in the most restrictive environments, which actually has an impact on the green agenda. But also there's a lot of what we're recognizing as we develop our role, not just on delivery of green, but on the role of the anchor, is that they're both inextricably linked. And so I think as we discuss the two agendas, we should increasingly talk about them together.
Thank you, Vanessa. I think that's really powerful. Helen, before passing across to Sarah for any final words on this agenda, was there any response that you wanted to make to those comments, which I think have been illustrative and broadly supportive?
Thank you, Chair. So yes, thank you. I completely agree. We need to embed green and sustainability into everything that we're doing. It shouldn't be a separate work stream. It needs to be part of it. An example of that was I was at the HIN workshop around virtual wards and their evaluation. And actually, I asked the evaluation criteria about sustainability to be added in there to make sure it was part of the totality of what we were looking at when we were looking at the benefit of the case. So actually, again, it's how do we start to think like, because we do many things that actually have an impact on the carbon footprint, and it's just knowingly making that decision, understanding that with that at the forefront of your mind, isn't it? So completely agree with that. Ruth, thank you for raising around Innovate. I think we've plugged into everybody, but I'm going to go back and check and make sure we are, because actually we need to take these opportunities, don't we, where we can find them, and let's see how we can work together more closely. But hopefully you can see, all of you, that actually we are making progress here. There's some great stuff going on, and as Jacqueline said, there's a real momentum with the staff and with the population about how can we get involved in this and what can we do, and we need to utilise that as we go forwards to make it better for everyone.
Fantastic, thank you, Helen. Sarah, final words.
Not much to say, is there? I think Helen said it all. I mean, the main thing is that I think this is our next pandemic, isn't it? We do know that this is a big priority, and it's how do we sort of feed this into every day. So really good that we're receiving the updates, really good that we're making progress, and we just need to continue, I think, to keep it on the agenda, Mike.
Thank you for that. Thank you. We'll move on to item 10, and Ben's going to give us an update on the BAF, the Board Assurance Framework, and I think there's been one significant change. So over to you, Ben.
Thanks, Mike. So as the board will now be getting used to, we bring the Board Assurance Framework here twice a year. The Board Assurance Framework, also known as the BAF, provides the board with an overview of our key high-level risks and assurance on the actions that we're taking to mitigate these. As you'll recognise, this is a living, breathing document that continues to evolve throughout the year as our risk profile changes. The BAF, along with our corporate risk register, are regularly reviewed by the Executive Director, risk owners, our SMT, individual committees, and including the audit committee in that as well. As you will have seen, we currently have 5 high scoring risks on the BAF. So that is risks that score over 15 and could have a significant impact on the delivery of our objectives as an organisation. And as Mike just alluded to there, we've added one new risk regarding oversight of the system quality for South West London. And while this isn't a high scoring risk, we felt we should highlight its significance to the board. And I'm sure if anybody would like some more detail on that, Elaine would be happy to speak to that in a bit more detail. I'll take the rest of the detail of the BAF as read, Mike. I'm happy to take any questions, and I know the relevant ED risk owners would also be happy to address any specific questions on individual risks.
Great, thank you for this. And Martin's committee does spend quite a lot of time working through the BAF and assuring themselves in relation to it. Martin isn't with us at this meeting, but very happy to have any other comments in relation to this. But if not, we will note it and note the important work. This is absolutely key to keep to ensure that we don't fall over inadvertently. Any questions, points, things that people would raise? I don't know, Elaine, whether you wanted to make any points in relation to the safety and quality oversight regime.
Thank you, Chair. Yeah, I think it was important to gather the concerns together in a risk in terms of the overall system quality risk, taking into account workforce challenges, the impacts of the ongoing industrial action. You know, we've talked a lot today about the winter plan and some of the challenges that poses. Implementation of PSERF, operational pressures, and some of the oversight and triangulating some of the oversight and support that the system gives to each other and shares learning. We felt it was important to recognise that in a risk so that colleagues are cited and know some of those challenges and what we're trying to do to mitigate and how we're trying to work as a system to learn together and support each other with those challenges.
Thank you, Elaine. I think, yeah, you're right. It was really helpful to have that as a single risk categorised and have sight of it in one place. Thank you to Ben and the team, but obviously this is something that reaches across the whole of the ICB, so all colleagues that are involved in that. Sarah, any final words before we move on?
Because Martin is not here, I just thought I'd maybe raise that he did raise the issue that some of our mitigated risks still have a very high level of risk against them, and that they will be looking at that in the audit committee to think about whether there is further mitigation. There are some areas we recognise where we don't have control over the mitigation, such as industrial action. However, you know, it's making sure that we have put all mitigations in place wherever we can, and that the board is assured that we have done that. So they will pick that up through audit committee.
Great, thank you very, very much. Key part of the ICS infrastructure alongside this board is the Integrated Care Partnership. I'm now going to pass across to my co-chair of that partnership, Councillor Ruth Dombey, to give us an update from the work of the partnership over the last couple of months in the last meeting. So Ruth, over to you.
Thanks, Mike. So as you all know, we had a big and successful partnership meeting back in May. A huge amount of work was done. Thank you to everyone that was involved in organising it. It was very productive, but there was a very strong sense that talking is fine, but we need to translate into action. So we took away a lot of the learning from that event and tweaked and made relevant changes to our Integrated Care Partnership strategy, which we've now agreed at the last meeting of the ICP board on the 20th of July. There have been some minor amendments, but the broad direction of travel was agreed, and also the various work streams. So now, of course, the real work begins, because we do want to translate this into action. We do want to ensure that what we're discussing here and bringing all the different partners together actually has an impact on the services that we're delivering to our residents. So we have our 6 work streams, and I'm pleased that each of the 6 Health and Wellbeing Board chairs are sponsoring one of the work streams. I've taken on workforce. I'm delighted that our priority of the partnership for the first year is workforce, and might listen to the conversations about winter pressures and also about children and young people's mental health. It's really brought home to me just how important this is, that we have enough people working in the sector, but also the right people in the right place and the right time. And I think the work that we're planning on doing around workforce will be really important, and will link to the other work streams as well. So that's all going really well. We have the next meeting of the Partnership Board on the 4th of October. We'll be looking at the Innovation Fund, which is now called the Priorities Fund, because we really want to ensure that the proposals that are being put forward for funding absolutely reflect our priorities. But I'm sure Zara and Alyssa will also be saying, I don't want to put words in your mouth, but you'll be saying it's really important there's clarity about these priorities and how we're going to ensure that the funding gets to the right organisations in order to promote our priorities. We are working very, very closely with the voluntary and community sector. And again, if I'm thinking back to the conversation we've just had about immunisation and vaccinations, we learned so much during COVID about the need to have trusted voices to reassure and encourage people to take up the various vaccinations and immunisations that are available. I'm very proud that yesterday I went along to my local pharmacy and had both my COVID jab, but also my flu jab, and I tweeted about it. And I'm sure, Charlotte, we can think about how the 6 boroughs and community and voluntary sector are able to promote some of what, I think you're right, Jonathan, there is a sense of people being jaded, but also complacency. And I do think we need to explain to people just how important it is that we get a good uptake of the various vaccinations and immunisations that are available, and how easy it is. Yes, you can go to your local GP, but also the pharmacy around the corner. And I think it's important that we promote all of that. I'm particularly interested to hear about the uptake in care homes, and that's something that I'll be looking at very carefully, because again, learning from COVID how important it is that not only people living in the care homes, but also the staff have the uptake. So that's something we can look at as a partnership again. And I think I'll stop there, Mike. Thanks.
Thank you. I mean, I think there is a real sense of engagement across the ICP, and I think that the May event that you referred to was actually really, really innovating for people, and I think that's really, really positive. Very good to see that we've got our Health and Wellbeing Board chairs leading the 6 work streams, and in addition to that, Sarah and I have had some conversations with our trust chairs, and we hope they'll be able to also participate in the work streams moving forward and provide that, so that we have real system buy-in across the third sector, local government, and the NHS. Thank you very, very much. We will move on to the board committee update and reports. If we go to Finance and Planning Committee, so if I could get Dick to open this section.
Thanks very much, Mike. Just briefly, so this our committee meeting was end of July. 3 things just to flag up. In our regular cycle of deep dive discussions, we were looking at Merton and Merton Place. Really great to see the quality of collaboration and the not just the structure, but the environment of that. We talked about the 12 projects that go with the Start Well, Live Well, Age Well approach. Really interesting, helpful stuff. There's a connection here in the discussion that maybe is for another day about how much we can leverage those sorts of interventions to shift mainstream funding, because of course there's a big inequality within geographic inequality within Merton, the east side of the borough. And that's probably something worth bearing in mind and coming back to. Just on the finance, as we'll hear from Helen in a moment, good to see we're on track on months 2 and 3, and I think that's a vindication of the taken the braver decision to say we're not going to break even in this financial year, but we're going to be clear about what we're capable of doing. That remains a risky strategy. We've got to stay on it. But I think that there's evidence from around the country that that was the right call. And then on financial recovery plan and programme, it was very good to hear how the governance has really been strengthened, and it does feel like a powerful system for driving our interrogation of the sort of transformation we need. This is early days reporting, but it seemed like it had already knocked out some issues about, are we all counting staffing and addressing staffing in the same way? I hope that as we go forward, the strength of what we've got in these early days will really help with the scale of clinical transformation we really need to deliver if we're going to reduce our costs and drive better care at the same time, which obviously a really hard challenge, let alone with the rest of the noise in the environment. So three areas. Felt a positive meeting that gave us a lot of assurance. Thanks.
Great, thank you for that. And we'll move straight across to Helen to provide us with an overview of the detailed report.
Thank you, Chair. So within the pack is the month 4 report. As you'll see, we are just £6 million adverse to plan, which relates to additional cost in relation to industrial action that we've incurred year to date. But it's also important to note that we're £8 million under on our activity trajectory. So therefore, we haven't earned £8 million of the elective recovery fund monies that we were due to. And this is neutralised within the position, with it being held in the ICB position as a surplus at this moment in time, while we understand that there are negotiations ongoing between NHS England and the Department of Health and Treasury around what guidance there is around the impact of industrial action on the finances of systems. So the key thing I think to really know is, obviously, in order to deliver this, we need to deliver the savings plan, the 210 million plan that we set at the beginning of the year, and that obviously is being affected by the industrial action taking up headspace for people and the time and the focus of what they need to do. So as much as we're pushing forwards as a system in doing that, we just need to know that that is really a big risk for us in being able to continue to deliver as we go, with the industrial action appearing to be ongoing at this moment in time. A highlight, though, that although we're over the agency cap, we can see a significant trend of the level of agency we're using as a system coming down, which is good news, and to see that some of the work streams that we've got are having an impact into that as we go forwards, even in these difficult times. And so I just wanted to highlight that to you. I'm happy to take any questions.
Thank you for that, Helen. And clearly, as the year moves on, the challenge becomes a little bit tougher, but it's really good to see that we're on plan now. And I know there's been quite a lot of adverse coverage in the national press about the NHS overall position, but it's nice to see that we're not a significant contributor to that adverse position. Sarah, was there anything that you wanted to add to the finance report?
No, I mean, excellent that we're on plan, not forgetting that our plan is a deficit plan. We need to remember that is still and therefore, really important that we try to keep to that deficit plan, because we managed to get that plan agreed with the regulators. We need to now make sure we deliver it. I wouldn't underestimate still how challenging that is. I think I would just flag that, which Helen I think has clarified, but with industrial action, everything else going on, it's still not easy.
Thank you. So big thanks to Dick and the committee, and to Helen and her team for working on it, but also to the Financial Recovery Board and all the people working so hard in terms of making sure that we can implement those really quite challenging savings. We're moving on to quality and oversight. Mercy has provided, the committee chair has provided her apologies for today. She's on annual leave. So I'm going to go straight to Elaine. Elaine, update on the quality report.
Thank you, Chair. I have been asked to look at how we present the quality report, actually, and I think that I'd be very happy to take any feedback or comments from colleagues. There's been some different suggestions about how we do present the quality report, so we'll look at that as time goes on. I'll take the report as read. I think things to highlight, I'll always go to the positives first, is the joint area inspection in Sutton recently, and that was positive. The really positive thing is the new implementation and transition to PSERF, which is the new way of monitoring patient safety incidents. South West London has really worked together as a system, shared learning and shared implementation. Some of our trusts have fully I can't even speak, moved over to PSERF. Some of our trusts are in transition at the moment and implementing, but the shared learning and collaboration across South West London has been commended from NHS London, which is a good thing. There's lots of learning still for us to do in terms of implementing and embedding those systems and how we start to learn from that going forward and pick up those instances and learn from them. You will note that our infection prevention control, the trusts are all working tirelessly with some action plans. We are seeing an increase in infection rates for a range of bacteria and infections across all of our providers at the moment. Again, that's not that we're not an outlier in South West London, but it is something that we're cognizant of. We've been talking about and doing quite a lot of work with our providers and as a system for that learning. I'm happy to take any other questions in terms of any of the highlights or anything that anybody would like to ask. Otherwise, I'll hand over to my colleague who'll talk about performance.
Great, thank you. If I can go to Jacqueline, first of all, and Jacqueline, I know that you've got about 3 minutes before you have to dash off this call, but over to you.
Thank you, Elaine. And I think I would support you in thinking that maybe we need to change the way the quality report is. I think there's loads of data about performance in here that are in SBC charts. We don't have that same richness to enable to triangulate for quality. And I think that's where we need to go, because it's great having what you've said here, but there's no data that supports or triangulates it in a helpful way. And I think that's been a very salutary lesson for St George's recently about how do we really triangulate the data. So I think that, and I'm happy to help if that's of any help at all, but I'm sure you know what you're doing. So that would be just my view on that, Mike, if that's okay.
No, that's really helpful. And I know, Elaine, what sort of timescale are you looking for people to comment in relation to the style of the report?
So I'll be honest, colleagues have probably started working on some of the next report already. So I think I've got time for colleagues to reflect on what they think it might need to look like. I think as we move towards changes in the ICB and I start to understand where we're at, we've got some months to be able to play with this. So as colleagues think about it, reflect on it, look at their own quality reports and think about what would or wouldn't work for this. I'm happy to have those conversations.
Right, and I think it's all, it is about assurance across the system, but it's also about making sure that we're adding value to the work that happens in our individual institutions and not duplicating that. So yeah, I know that we're looking at the quality and oversight committees in terms of reference and membership as well. As part of this process. So again, any views on that, please pass them through to Elaine, and we'll make sure that they get incorporated into our future planning for the new year. Jonathan, over to you for performance.
Thanks very much, Mike. Obviously happy to take any comments that people have on the attached performance report. Just to highlight, as I often do, sort of 3 positives and 3 areas of challenge. So and trying to remain consistent to the conversation we had earlier about winter planning too. So I think progress on particularly long waiters around ambulances, I'd want to call out. I'd like to note, and I'm sure people have seen it in the national press, but the movement to 3 cancer standards, and obviously will reflect the reporting on that. It'll probably be December before we actually start seeing the data reported here in the board on the 3 new cancer standards rather than the 9 that we previously have and reflected in this report. However, what perhaps the most important, telling people whether they have a cancer diagnosis or not, the faster diagnosis standard as it's called. We are already meeting the national ask, and we're one of the few ICSs in the country that are doing that. So that would be my second one. And my third would be to note the improvement we've seen in access to psychological therapy services, which is really good to see after a period of significant challenge. And the 3 areas of challenge, 2 of them around emergency care, the length of time people wait, whether they have physical or mental health issues in our emergency department, where we are something of an outlier, particularly for the physical health aspect. And again, strongly linked to the industrial action and from a very strong base, I would add, but the growth we've seen in patients who waited more than a year, more than 52 weeks to access elective care, and some particular challenges in specialties like gynecology and community paediatrics that we're regularly talking about across the ICS at this point in time. So those will be my 3 positives and 3 challenges, Chair, and again, happy to take any comments people have on the main report.
Thank you for that, Jonathan. Are there any comments, questions, points of interest or clarity that you'd like in relation to that? Can't see any pressing points, Jonathan. So thank you all for those reports. We'll now move on to our last substantial item, which is over to Sarah for the Chief Executive's report.
Thank you very much, Chair. There's only 3 items on there, but I think they are, well, the first one in particular is a very important item, which is the terrible situation around Lucy Letby and what happened in that trust. I think, you know, trying to articulate how the NHS feels about this is really difficult, because I think generally we are all shocked and saddened by what has happened, but also want to make sure that we do everything within our power to make sure that nothing like that can happen within our organisations. So everyone is working hard together to make sure that our staff feel able to speak up, and that that there is an open discussion with our staff around the level of quality of care within all of our parts of our system. So, you know, and I do say that I know that all of the organisations in South West London are looking at that. However, we still await, I think, the formal outcome of the review that's happening and the investigation, because there will be more learning for us, and that we will take that on board as that comes along. So so I just thought I would mention that in public, and you've seen what we've written there. We've also had the annual assessment of the ICB from NHS England. It's quite a long read. We have attached it for information. I wasn't going to go through this in detail, just to assure the board that anything that is mentioned in there, we are picking up through our usual business. There is quite a lot of detail in there. These are the things that we do on a day-to-day basis as part of the general running of the ICB. So so they do actually commend us around particularly some of the work that we do with the communities, which I thought was very positive. But there is also, there's a lot of good stuff in there, and there are some areas where we might need to improve a bit, and we will be working on that. And then finally, in my report, there was something there on the management cost savings. We are hoping to be able to launch the consultation with staff shortly around the new structures that we're going to be putting forward as a management team. We are meeting with yourself, Mike, and non-execs to just go through that, and there will be an ongoing process of consultation and review. And we will let the board know regularly how we are getting on with that. So we will report back on that at a later date. And you also mentioned to me, Mike, and I have picked that up, that we also should mention Martha's Law. So Martha's Law was an area where, very sad case where a 13-year-old died when they felt they should have had a second opinion. And now Martha's Law is making it clear that we will need to be able to offer that second opinion, and making it clear to patients and families that they can ask for that second opinion. So we still await guidance on exactly how we're going to implement that, but we'll be working across all the providers and with the ICB to make sure that we implement that in a way that makes sense for both our staff and patients.
Sarah, thank you for that report. Can I ask colleagues if there are any questions for Sarah? This is the problem of the 3-hour meeting, that by this point in the...
By the time it gets to me, nobody wants to ask anything, which is great. I'm fine with that. I am absolutely fine with that.
We have to make sure that you're held accountable, Sarah. Okay, thank you all very much. Thank you all very, very much. I haven't been alerted to any other business. Can I assume there is no other business? I can't see anybody wildly signalling that they have an urgent item. So I'll bring this part of the meeting to a close, and we'll move into public questions. Ben, can I ask you to, we've had one public question, I understand. Could you read it out for us?
Yeah, of course, Mike. Thanks. We've had one question from a member of the public, so from Wendy Micklewright. Unfortunately, Wendy can't be with us today, but as always, we look forward to seeing her at our next in-person meeting. Wendy has asked about the ICB's plans to ban electroconvulsive treatment. Wendy, I know we've addressed this in our last couple of boards, Mike, and Vanessa has spoken to this in the past, but you or Vanessa might just want to say a little more on that.
I haven't got more to add from my last update. Suffice to say that the board has been fully briefed and circulated, and I recognise Wendy's passion and commitment to continue to raise this matter and our differences agreed approach, I think. And I'm happy to obviously always discuss this with Wendy. We have frequent conversations.
Thank you for that, Vanessa, and Ben, thank you for bringing forward the question. Our next meeting strikes whatever else permitting is 26th of November. That is going to be at the Chaucer Centre on Canterbury Road in Morden. Could I just check, because I know we're changing meetings from morning to afternoon following public requests. Is this meeting a morning? Is this the last of the morning? This is the first of the afternoon meetings.
We're going to start that from next April, Mike. We had all of our board meetings this year scheduled in, and it was difficult for people to accommodate them at this notice. So we're going to start that from April. So our first one will be May, and yes, we'll be moving to an afternoon format from that point, so that members of the public can travel to and from the board on their freedom passes if they have one.
Fantastic. Thank you for that, Ben. Good to see that we're responding to public requests. And let's hope that we have the next meeting in person, because I know that many of our public do not like remote meetings, can't join us, and we certainly don't have the capacity to take questions from the public, which we always do at our face-to-face meetings. On that basis, I will close the meeting early. That gives you all of an extra 25 minutes of your life back. Thank you all very, very much, and look forward to seeing you at the next board meeting, and no doubt in between times. Bye-bye now.